to all, and welcome to the Alabama Public Health Training Network. Thank you so much for joining us today for our 2018 Alabama Department of Public Health Nurse Practitioner and Nurse Fall Program on EHR documentation. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and nurse practitioners for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credit will only be awarded for 1 year for nurses expiring on November 30th, 2019. I'm Beth Allen, Nurse Practitioner Director for the Bureau of Family Health Services at the Alabama Department of Public Health. Before we get started, I would like to welcome some of our audience. We have with us today Kay Melnick, our Chief Nursing Officer for the state nurses, and we have our EHR staff, Lori Stout and Julie Teal. We have our Women's Health Director, Ms. Jessica Hardy, and members of our Family Health Services staff in the central office. Later today, Dr. Grace Thomas, Family Health Services Medical Officer, and Dr. Dina Maxwell will join us. She's our Senior Physician Consultant for the Alabama Department of Public Health. So let's get started with our first presenters. Our Nurse Practitioner Seniors today are presenting our program, All Things EHR, right? So the first two presenters are on stage now. I want to go ahead and introduce all four. Deborah Davis, Nurse Practitioner Senior, Krista Hood, Nurse Practitioner Senior, will be in the second hour. But to begin now, we have Dewana Tatum, Nurse Practitioner Senior, and Nasa Hernandez, Nurse Practitioner Senior. I'm going to turn it over to you ladies.
Thank you, Beth. Good morning. I hope you're all doing well today and staying warm wherever you're at. The objective of my presentation this morning is to describe the components of electronic record documentation that are required to support the evaluation and management coding, such as HPI, HPI, review of system, assessment, and plan. So first, what is evaluation and management coding? It is the process by which physician-patient encounters are translated into 5-digit CPT codes to facilitate the billing process. Basically, it is what you do to the patient, any procedures or services that you do to the patient. Now, what are evaluation and management codes? They are visit codes that represent the level of service provided by the nurse practitioners. The code must be supported by the provider documentation. So let's stop here for a minute, okay? Documentation is and has always been something very important. We know how to document, we know what to document. We all know that, okay? So don't stray from what you know. What happens now is we're looking at things through a different set of eyes. We have another component that is tied to our documentation, which is the billing process. Now, even though we're not billing right now, we still have to document with billing in mind, because everything that we do needs to support that visit code that we're using. So we need to know exactly what we need to do and what we need to document to meet the necessary levels of those evaluation and management codes. Your visit must stand alone. The person that is doing the coding and the billing cannot fill the gaps for you. You have to make sure that everything that is needed in that documentation is in there. Nobody can do it but yourself. And you guys are doing a fabulous job with documentation based on our audits and looking at the records. You're doing a great job. We're just trying to standardize things and make sure that we're all doing exactly the same things the same way. So remember, you cannot bill just for what is done. You bill for what you do and for what you document. So if you do it, you document. Otherwise, it was not done, it cannot be billed for. So what can be billed? In summary, any service provided to the patient that is documented in the medical record. Every component needs to be objectively quantifiable and medically necessary for the treatment of the patient's condition. There is no room for subjectivity here. Everything has to match. You cannot say, okay, this feels or looks like a 99214 visit. It is a 99214, you know it is, but your documentation, your notes need to prove it. So keep that in mind, okay? You need to have the necessary documentation to back up whatever code it is. Now, the components of evaluation and management codes. There's a total of 7 components, but only 3 are key, and those are the 3 that we're going to be discussing today. Is the history, the physical exam, and the medical decision making. I will be talking about the first 2, and Joanna will be talking about medical decision making on the assessment and plan section. So let's talk about each one of these individually. And this is something, again, something we've been doing. It doesn't matter if it was paper record, electronic, we were doing history, we were doing physical, we were doing the medical decision-making process. But now let's talk about the history. History by itself has 4 subcomponents: the chief complaint, history of present illness, past medical family social history, and the review of system. So we're going to touch each one of those individually. Chief complaint is the number 1. It is important because the chief complaint answers the question of why the patient is here. What is the patient here for? So whenever you're interviewing the patient, that's the first thing you're going to ask. What can I do for you? What are you here for? So whatever the patient answers, that's what you're going to write on the chief complaint. And it's usually going to be stated in patient's own words. And every medical record should clearly reflect, every visit should reflect the chief complaint. So you type whatever. Patient comes in for an annual and patient tells you, I'm here for my annual exam and my birth control. That's the chief complaint. I'm here for my annual, I have a vaginal discharge, or I have headaches, whatever it is, that's going to be your chief complaint. Very simple, 1 sentence. Now, history of present illness. This is one element of the medical history. Again, this is something we have been doing all along. Different format. Before, we were using the SOAP notes. So on the CHR 12, on the top of the page, we were writing the history of present illness. We just did not call it that way, but we were doing it. Then we were doing our exam, and in the bottom, we were doing the assessment and plan. So the HPI is a chronological description of the present illness from initial sign to the present. Now, unlike the chief complaint, the HPI cannot just be 1 sentence. The HPI, you have to build it. It has to be a little bit more complete and more comprehensive, okay? It cannot be just 1 sentence, even if the patient does not have any complaints on the visit day. And we're going to talk a little bit more about this, okay? So when you're building your HPI, there's some things, some elements that you need to keep in mind. And they're listed on the slide. Location, quality, severity, duration, timing, context, any associated signs and symptoms, and modifying factors, okay? So now, I'm going to cover some examples of HPI. Before I do that, let me explain a little bit of what is expected when it comes to HPI documentation. Right now, when you enter the chief complaint, it will populate an HPI. But it's very simple, it's very basic. Patient comes in for an annual, HPI, no complaints, HPI will say 23 years old, in for an annual exam and birth control. End of the story. So this is where the next nurse practitioner comes into the picture. I need you to build up this HPI. And I don't want you to think about this like, oh, this is something else that I need to do now, you know, something else adding. This is something, again, that you have been doing. It's just that now I want you to do it, and you're going to put this right under the HPI box. You're going to free text this HPI. And this is going to be a summary of the reason why the patient is here and any signs and symptoms associated with the chief complaint. So let's take a look at some examples here. This is from one of our nurse practitioners. Patient comes in for family planning annual exam, wants to continue with her IUD, which was inserted by Dr. Flintstone on August of 2014. She voices concerns about having a yellowish, heavy vaginal discharge for 3 days, no changes to the medical history since the last visit. And this particular case, the HPI was 28-year-old female patient, presents with birth control annual. This nurse practitioner took the time to, and you're doing this when you're reviewing the medical history, I want you to start thinking and making this picture in your head, okay, of what it is that's going on and what are the things that you need to know to do the birth control, or if you have to do a consult, you need to start making this picture and put it in writing. But this is a very complete HPI, and it covers some of the elements that I talk about, talking about heavy yellowish vaginal discharge, talking about the location, the duration, the severity, and how it looks. So this right here covers at least 4 of those elements on the HPI. This next one here, I don't know if you will be able to read it on your computers, but it is one of our nurse practitioners as well. It's a very complete HPI. This particular patient comes in for an annual exam, birth control pills, and she's not having any problems. At least nothing else was documented. When this nurse practitioner reviews the history with the patient, she took the time to talk about previous birth control method, current birth control, why did she change it, she was having problems, what kind of problems. So she was very specific on the history of this patient here. And this is something, you know, it depends how extensive it has to be. It depends on the history, on the medical history of the patient and the extent of the problems they're having, if any. And something else I want you to think about too, even though if you have a patient that has no complaints, you still can develop that HPI and meet the elements. We are dealing with GYN patients. So when you're doing the history, you can go ahead and talk about the period, last menstrual period, patient using condoms, not having problems, last menstrual period, 9/15/18, patient states they last 3 to 5 days, they're really heavy. So that will cover those elements of the HPI. So you can build that around the gynecological history of this patient as well. This one here is another example, another great example, and this basically is what I was just telling you guys. This patient did not have any problems. The NP counseled on hormonal contraception. Patient did not want any, so she expanded on the LMP. The frequency, how heavy they are, and any problems that she was having with. And this patient was having also, apparently, based on this, she had a high blood pressure reading, so she talked about this on the HPI. So these are things that are happening right now with this patient. And in this case, the nurse practitioner signed her name. So I want you guys, when you enter your HPI at the end, you enter your name, first name, last name, and your title. Nessa Hernandez, CRNP. And I want you to do it that way. But this is another example of a great HPI. Now, these two here are 2 examples of HPI. The first one, 33-year-old female patient comes in for an annual exam, and she wants her IUD removed. End of the story. So I don't know, why does she want that IUD removed? Is she having problems? Is the IUD expired? So these are things that you can use to expand on this HPI. In this particular case, the nurse practitioner did expand on this, but she did it on the assessment part. So I don't want this in the, I want you guys to do this, summarize this at the top of your documentation, which is where the HPI is. That's the first thing that we need to be able to read when we open this record, is the history of present illness. That will give us an idea of what it is that's going on with this patient. Plus, it will make it easier for our doctors when they review the history for consultation purposes. And Joanna will be expanding on this a little bit more later on. The second case, she's 19. She comes in for an annual exam and a supply visit. She wants pills and she wants something to help with her acne. That's all we have in the HPI. On the medical history, there's one sentence that says this patient has a pacemaker because she had low heart rate. That's all we know. So why this 19-year-old has a pacemaker? What happened for her to get this pacemaker? So in this case, there's nothing on the medical history. The NP expanded a little bit on the assessment part, and then mentions that all the medical records are under the document section. Yes, they are all in there. I was able to pull them. I was able to read the whole story, but it takes a while. If this NP had done a summary of what was going on with this patient, it would have given us a clear picture of what was going on. So this is really trying for you to understand the reason why we want you to do it this way and summarize things. And this patient also was a consult for birth control. Okay, the next component of the history will be the past medical history, family history, and social history. We're very familiar with this. We have been doing this. We know how to do this, okay? Now, it's very important, again, that you focus on the things that are necessary. Past medical history. Patient broke her leg when she was 7 years old. Is that important? Not really. I mean, will that make a difference for her birth control? No, it will not. So try to think on relevant things. Family history, does it matter that grandmother had arthritis? Maybe not. So just think cardiovascular history. My parents had high blood pressure. Yes, that will probably affect your patient down the road. Any gynecological type of cancers, any female type of cancers, those are things that you need to focus on and document. And especially on cancers, you know that increases the risk, you know what to ask for, what age, and that way you know how to counsel this patient. And the social history, any factors that will affect the patient's health, such as smoking, alcohol consumption, or any other stressors in their life. And the last component of the history is the review of systems. The review of systems is an inventory of body systems obtained through a series of questions trying to identify signs and symptoms that the patient may be experiencing at that time or has experienced, okay? Now, we know the nurses can complete the review of systems, but the nurse practitioner must review these for accuracy. And again, everything has to add. If you have a chief complaint of a patient that is complaining of headaches, don't deny everything on the review of systems. It's very easy just to click, denied, and just do it all. Everything has to match up, okay? If she complains of a headache, that needs to be reflected on the review of systems. So we already covered the history. We're going to talk a little bit about the physical exam, which is the second component of the evaluation and management codes. So your physical exam, again, you know how to do this, but it's very important that we are as specific and as clear as possible when we document the exam findings. Again, it is a lot easier to just click normal on everything, but we need to be specific. I mean, if something ever happens, if this patient comes back and ends up with, I don't know, skin cancer, and she's had this lesion on her back, and you document under the skin that everything was normal, if something ever happens, they're going to question that. Well, this was normal. Did you see this? How big it was? Well, maybe yes, you did, but you did not document. So get in the habit of just be very specific. Now, this is something else. When it comes to the physical exam, there's some requirements. You need to complete so many organ systems when you do your exam. I'm not going to go into the specifics of these and say for this visit you need to cover 5 organ systems, and for this one 7, and for this one 9, because this is pretty much all-inclusive. If you complete this physical exam, you are covering all the bases, so we will not be missing anything. But try to be specific: skin, grossly normal, no rash or lesions, cervix, uterus, normal size, position of the uterus, instead of clicking normal. Be descriptive as possible. If you have a breast mass, if you have a vaginal discharge, all these things matter, and it will make a difference. So this completes my section. I will leave you guys with Ms. Dewana Tatum.
Good morning, everyone. I'm going to begin today talking about the medical presentation, and then I'll conclude with the assessment and plan portion of the SOAP note. So my objectives today is to ensure we're giving the best medical presentation, either written or by phone, in order to receive the best management plan from our collaborating physician, and also to review the documentation of the assessment and plan. So we're going to get started with the medical presentation. So presentations is just a way that we tell medical stories to one another. Think about it as painting the picture for the physician so that she can really see what's going on. When you present, you want to ask yourself if you've described the story in an accurate way. Will the listener be able to see the patient the same way that you do? So you want to make sure that as much as possible that the care you provide after consulting had been the same care that the physician would have recommended had she been there to do the exam herself. It is the job of the presenter to share the pertinent facts of a patient's case with a collaborating physician and to establish a clear diagnosis and treatment plan. The presenter should strive to include details to support the proposed plan of care. So no matter if you're the nurse practitioner calling the physician or the registered nurse calling the physician, you want to have details and try to anticipate questions so that as much as possible they can give you the best management plan. You know, phone consultation has always been a big part of what we do as nurse practitioners, and over the past year the registered nurses have also been included in this process. They help expedite patient care and to make sure that no patient leaves without a good method of birth control. Calling the physician is really nothing new for nurses. I mean, we learned to do that in school. But it's something that is kind of new at the health department. So today I'm just going to give a brief overview for the nurse practitioner and the nurses of some details they may want to have available when they call the physician. So you want to think about the clinical situation that you're presenting. You know, you want to provide a clear picture without too much insignificant information that could cloud the actual problem. So you don't want to start with, I have a young, sweet 20-year-old girl that wants some birth control pills. You want to start with more specific details. You want to start with their age. You want to go with their gravida and their para. You know, was this a vaginal delivery? Did this patient have a C-section? They may ask you that. And the significance could be, you know, we know people have C-sections because of failure to progress or fetal distress, but they also have C-sections for other reasons. You know, was this patient preeclamptic? You know, did she end up in the unit with cardiomyopathies or maybe even had a stroke? So that is definitely going to change the management plan in that case. The chief complaint, what are you calling the physician for today? So what's the main thing you're looking at today? You want to have the vital signs present. You want to know any labs, you want to know their pregnancy test. If you're calling about bleeding, of course, you want to know their hemoglobin. You want to know the last menstrual period. History of present illness. If you need to elaborate more on your chief complaint, you know, you can, do that here, and you can include any relevant review of systems. Does the patient have any other active medical problems? You know, does she have seizures? Is she, have migraines? Is she taking Topamax or Dilantin or anything that could affect the management plan for the physician? You want to give a brief social history if relevant. Does your patient smoke 2 packs of cigarettes a day? That's going to make a difference. The physical exam. You want to be sure you examine the patient before you call the physician so you have all the pertinent findings available. And then, of course, you want to have your assessment and plan. So you want to have your plan developed when you call the physician. You want to talk to your patient. You want to know what they're willing to take. So you don't want to call the physician and get an order for depot, and then your patient's like, I don't want depot, I want something else. So what they're willing to take, what's available, and then try to make your plan from that. And I know that's not always easy. We have a lot of complicated, sick patients with comorbidities and just really sick. So try to just be thinking of a plan when you call the physician. The last thing I want to say about phone presentations is just remember that your phone presentation and your written assessment should coincide with each other. So that should kind of mirror. So once you hang up the phone and you start writing or documenting and you think, oh, I forgot to tell her she had a heart attack 2 years ago, or whatever. If you think of something important, you need to pick the phone up and call them back and let them know that you left that important detail out. Just to touch briefly on the physical exam, you want to avoid general descriptions. You want to try to be colorful. You want the listener to be able to visualize your patient. So, if you have a patient that comes in with abnormal uterine bleeding, you could, when you call the physician, you could let her know that I did the speculum exam. The cervix is smooth and pink. There was a scant amount of blood in the vaginal vault. So you want to be thinking about things, how you can explain things. You want to quantify bleeding. You want to say if they have mild bleeding, it would just be minimal amount of bleeding in the vaginal vault. If they have moderate bleeding, when you put the speculum in, there could be blood pooling in the vaginal vault. Or if a person has heavy bleeding, when you put the speculum in, you could have blood just, everywhere. So you want to key in on what the complaints are and what you're calling the physician for. This is the phone consult template that Christy Wilkinson, the Assistant District Nursing Director in the Southwest area, developed for her nurses when they first started calling, just so they would have some information when they do call the physician. It may not be all-inclusive, and, it may need to be updated as time goes on. But this is just to get you thinking, there's various ways. Some people write down a lot of information, so when they call the physician, they don't leave it out. Some people are confident without it. But even saying with all that, there could be a time, even as prepared as you are, that the physician is going to ask you a question that you really don't know. And that's okay. You just say, I don't know, and call them back. So they're acceptable to that. Okay, so now that we've talked about the consult process, and NACE has reviewed the subjective and objective information, I'm going to finish with the assessment and plan, because we know we want our documentation to show that we did provide outstanding care. Your assessment is just your impression of the patient based on the subjective and objective data. So really, this is your opportunity to pull together all of the subjective and objective findings that you find, that the patient tells you and that you find on your exam. You want your assessment to be concise. You want it to be a summary of all the information that you put together. So if you've done your history of present illness correctly, like NACE talked about, you're going to have all that information there, so that you're going to be summarizing your history of present illness and your assessment. So all that is, is going to be in the history of present illness. So this is just kind of an example of some of the things you might want to include. It's not all inclusive. Each patient is different, and each scenario the information would change. But you want to include the age, the gravida, the para, any pertinent vital signs, any pertinent labs. If your patient is bleeding, you definitely want their hemoglobin and their pregnancy test noted. Any pertinent medical history. And what is the reason for the visit today should be included in your assessment. So I just have a few examples of assessment. I'm not saying this is the exact way to do it, but this is just some examples to get you thinking. This is a 35-year-old gravida 2, para 2, negative pregnancy test with a history of migraines with aura. She's in for her family plan and annual. She's established on depot and desires to continue with current method with no specific complaints today. So that's just a concise summary of everything you put in your HPI. Just another brief example, a 23-year-old Gravida 1, Para 1 with a history of hypertension for 2 years and control with PO meds under the care of PMD, in for family plan and annual, and desires to continue with depot. No complaints today. An assessment, of somebody that's complaining of discharge would, could be vaginitis, and you did a wet prep and was diagnosed with trichomoniasis. Or if they have a history of anemia, you could document that it's stable with a hemoglobin of 12. So there's various things you may or may not want to include in your assessment of the patient, depending on your patient's scenario. So your plan is basically, what are you going to do about your impressions? What interventions did you do during the visit? What medication did you prescribe? Is there any follow-up for this patient? What further testing or investigation is required? Did you consult somebody? And if so, what is your consult question? And if you had any referrals to any outside specialties. So I have a few examples of plans that we're going to take a look at. But first I want to say that, there are many different ways to document your plan. Some people document in the narrative format. Some people document by listing, their plan. So either way is perfectly acceptable. So whatever you do, I'm not saying change it. I'm just saying there's different ways that it can be done. So I'm just going to show you an example of one that was done by listing their plan. So this was an example, number 1, contraceptive management. She wrote the order to continue with depot per protocol times 1 year, the side effects, the calcium. Number 2, migraines with aura, report any changes in migraines. That is something important we want to make sure we tell our patients. Patient with a BMI of 39, she discussed diet and weight management. This was a patient with a history of hypertension. It was controlled. It was managed by her physician, and she was on meds. This is a history of hypertension uncontrolled. Blood pressure 150/100. The patient was non-compliant with her meds, and the order was okay for limited depot, and we'll reassess at 3-month supply visit. So these are just different ways that you can document, so if you want to document it all together, that's perfectly fine. Your consult should go in your plan. So now if you do a phone consult, you do want to say, see HPI, because that's where all the identifying information is going to be. So the physician is going to look there first. When they open your chart, they're going to look there and they're going to see what problems this patient's having. Then she's going to look at your assessment and your plan. So this just said phone consult to Dr. Maxwell for contraceptive management, and prior conversation will continue with depot per protocol times 1 year. That's just one way to document it. So I'm just, whatever you're doing. This is a written consult, see HPI, because that's where all that important information is. We'll continue with depot per protocol times 1 year. Do you concur with this management? So you want to make sure that, you ask the question what you want to know. Be specific on your question for that. This is just another plan for that patient that had vaginitis. She was diagnosed with trich, and the treatment, was documented in the plan. So this is an example of an incomplete assessment. So we'll look at that. The assessment was the GYN exam appears within normal limits. So one thing you want to do is, as the clinician, if the exam is normal, then it's normal. And if the exam is not normal, then it's not normal. So you want to avoid vague terms like appears and seems. You want to call it what it is. It's either normal or it's not normal. So even with this statement as the assessment, even with the HPI as detailed as it is, we still need to make a summary of this patient here under our assessment. Now her plan was her PAP was due. She documented that. She documented her breast exam, the depot. She made the order, and she discussed exercise. She told her when to come back. The consult was stated, BMI 42, age 33. May patient have depot with monitoring and counseling. So really the question is, what is the question? Because why what else is going on with this patient? Why wouldn't this patient be able to have depot? So the physician now is going to have to try to figure out really why are you asking me this question? So when we do a consult and have a question, we need to be specific. We need our HPI to be complete, our assessment to be complete, and our question to be concise. Just a few documentation tips. After you do your consult, your written consult, and you assign it to your physician, we know that we're sending an EHR message to the physician. So if you're in the patient's note, the easiest way to do it is when you're in the patient note, if you'll go to the tree on the left-hand side and click on Message, and then compose the message from that tree, the patient is automatically attached to that message. So all the physician has to do is click on that name, and it's going to take a right to that note. We don't want the EHR number in the attachment. We want the name so they can click on that. And then, of course, in your to box, you're just whoever you sent your consult to. The CC, the nurses will CC their supervisor and their nurse practitioner, and the nurse practitioner will CC their supervisor and their NP senior. In the subject line, you can just put consult, and then the patient will be attached. Now, in the body of the EHR message, you really don't have to put anything, or either you can just put consult. So we don't want a lot of that information there. We don't want your assessment or plan there. So really you're just sending the physician a note saying, hey, I sent you a consult, so it's a checks and balances. The nurse should always call the physician prior to entering the consult into the EHR, though. Another tip is if you assign any lab or review for the physician to review, you need to append your original note and add your question at the bottom so the physician knows why you're sending the note. So for example, you will go back and append your original note. You could make a statement like, Dr. Thomas, please see thyroid results. I'm referring this patient for evaluation to Dr. X, Y, and Z, the endocrinologist, and will continue with depot. Do you concur with my management plan? So I think that's very clear, and she knows exactly what the question is. For a PAP consult, remember if the patient has not been in EHR, the consult will still be done through Lotus, but otherwise it will go through the EHR. So in conclusion, a consult is not a one-way handover. It's just a way to ask for help that leads to shared responsibility between you and the collaborating physician. Consults are a requirement for all nurse practitioners, at least one new consult a week to meet minimal standards. Remember, the phone consult and the written note should mirror. And you want to document your assessment and plan in a complete and clear method. And that wraps it up for me. I'm going to send it back over to Beth to see if there's any questions.
Yes. Thank y'all very much. Very informative. We do have one email question that I would like to read and then us respond to. And this comes from Marshall County. I believe the number is on your screens there if you want to call in, and the email address is listed there if you would like to email us. But we do have, we've made time for questions, so please do ask your questions now. We know these are changes, so we want everybody to understand these changes. So I'm going to read this question. We have a question about the reason for the visit, and this comes from Marshall County. The reason for the visit is a pre-populated text. You're not supposed to add more than what is on the system, even though you have the ability to do this. Only the pre-populated text is what's supposed to be selected. This is what we were told when the EHR first rolled out. We can give further details in other boxes provided, but as far as choosing the actual wording that the patient says for the reason of the visit, our understanding is that we don't do that. So I'm going to start there. There's two parts to this question. We do realize that there are pre-populated check boxes that are part of the history of present illness, and those can be used certainly. And by some of those boxes, or once you check those, for example, by description, once you check that, you can actually free text in a box the description of what is going on with that issue or that problem. But you can also free text underneath the total section of the HPI. You can actually free text there as well, and should, if needed, with that patient. So I hope that that answers that question. So if you check all the parameters that are listed in the HPI, underneath that total section is a blue line. Underneath that blue line, you can write your free text. We've looked at this and worked through it, because that summary needs to be so very complete, just like Nasa and Dewana just talked about, so that it's very thorough to completely have all the components and elements needed to build that HPI appropriately. That summary is very much needed as a part of your total HPI. Okay, and then the second question is, under the reason for the visit, there are all these different boxes for the elements. Can we fill this out instead of free texting a paragraph? We have been clicking the description box and free texting any additional information needed. Is this okay? So yes, this is okay. If your description includes 30-year-old, Gravida 1, Para 1, N4, family planning revisit, and you are able to describe all the components needed to build that problem for that visit, whether there's no problems and you're saying that it's a patient established on depot and they have no problems, you're actually stating that. Those kinds of things are what needs to be summarized, because you don't get that from just checking off the elements. If that doesn't answer your question from Marshall County, please call us or email again. But I hope that answers your question. Do we have any other questions? Just going to check. So just in summary, and I'll let Dr. Thomas have some comments as well, but where we've sent information in the past as far as the way that you would present your history of present illness, we didn't really tease out that that description would go all with your HPI. Oftentimes when I emailed you about consults and the way you present things, we talked about that going in the assessment and plan. So for clarification purposes now, the meat of that, if you will, the information for all the patient history of present illness needs to go with that HPI. And then the assessment and plan can be a summary of that at the end of your visit. If you have any questions about that, please call us or email us. Dr. Thomas?
I really don't have anything else to add. I just want to thank Nasa and Dewana for an excellent presentation. And again, I guess I can reiterate that the HPI drives payment for the patients that we see, and I think that is the fundamental difference here in how we did business in the past. So I think for those of you who have been in private practice, you know this, and there is nothing that is being done differently in terms of the information that you've captured previously for your patients. So it's putting it in a concise fashion and putting it in that free text box so that all the information is captured. I just wanted to also clarify for the registered nurses who are calling in with consults or for consultation, first of all, to thank them for doing a bang-up job in terms of expediting patient care and moving patients through the county health departments, and so patients are not turned away when a nurse practitioner is not there. When you do call, the registered nurses, again, I want to clarify that, it's out of the scope of your practice to come up with a diagnosis. So we're really not, I don't think any of the physicians expect the nurses to come up with a diagnosis. However, if a patient comes to the health department and she has a complaint of vaginal bleeding, a speculum exam is always expected, so that is warranted, I should say, so that please ensure that that's one of the things that is performed or done before contacting the collaborating physician.
I don't think we have any other questions, so we'll go to a break, and that will allow us time to start a little early on the second portion of our program. Thank you. Welcome back, and I just wanted to make a couple of clarifications. Just want to make sure we're all on the same page with our HPI around our question that came from Marshall County, and thank you so much for sending your question. The HPI, the reason we want the free text, it really crystallizes, it summarizes and makes it crystal clear as to what are the elements of the HPI. So that's why we want that free text summary. And that also is very important for the billing piece. We've had questions from billing about the way we've been building our HPI. It needs to be very much crystallized so that those components and elements are there. And that summary will do that in a nutshell, if you will. So just wanted to make sure that you understood why we were wanting to change course with this a bit and add that free text to the HPI. So with that said, we look forward to jumping into the second portion of our program. And I made introductions early on, but I'm going to again introduce Ms. Krista Hood, Nurse Practitioner Senior, and Ms. Deborah Davis, who will be the second portion of our second half, Nurse Practitioner Senior. And I'm going to turn it over to you, Krista.
So as Beth said, my name is Krista Hood, and I want to go over my objectives for my presentation. So the first thing we're going to discuss is the documentation of abnormal findings. So this could be breast or PAP follow-up, and how we're going to do these, how we're going to document our findings, and how we're going to document through CureMD. I want to also review the use of the referrals, the task, and the functionality of the notes portions through CureMD, and how we utilize the referral system or our progress note for follow-up with using some case studies as we integrate the care of patients. So I'm going to just jump into just a basic case study to start follow-up, talking about follow-up. So if we have a 34-year-old female, she presents for a family planning initial. She's gravida 2, para 2, just basic, no abnormal PAP history, no abnormalities upon exam. So the patient is not in the health department, so it's time for follow-up when we get her PAP smear back and it's abnormal. So she has a low-grade PAP and it's HPV positive. So let's look at the ASCCP algorithm for this. And I want to talk a little bit about the changes with our follow-up section as we look at algorithms. So for this patient, she has a low-grade PAP, and she is also HPV positive. Really, regardless of her HPV finding, she would go to colposcopy because of her age. So as you can see, there's several different arms to some of these algorithms, and you have to make sure you're reading the correct arm so that you know how to appropriately manage the patient's care. So you can see this one, you have 3 green boxes, one that says LCIL with a negative PAP test, negative HPV, low grade with no HPV, or low grade with HPV positive. So she was HPV positive, the arm says go to colposcopy. We've had several questions about the ASCUS arm, which I don't have a picture of that one, but it is in your follow-up chapter on page 18. Another thing I want to say is if you're at your computer or you have a laptop and you want to follow along in Cure, we're going to talk about how to function and how to kind of navigate through that system. So it might be helpful if you're in the CureMD environment. But just talking about the ASCUS PAP smear. So there's 2 different arms on the algorithm I'm looking at. One says just with ASCUS, it says repeat cytology at 1 year. But then if you have an HPV test that was done, depending on whether it was positive or negative, it gives you your recommendation for follow-up, whether you go to colposcopy or whether you repeat co-testing in 3 years. So it's really important to kind of just follow through these algorithms. I know it's a different way of looking at the follow-up and reading them, but I think it'll get easier the longer we look at the algorithms. Okay. So my first question pertaining to follow-up is, where do you document your recommendations for follow-up when we're talking about the lab results section? So you have the PAP smear that comes back, and hopefully it is attached in this lab results section as a PDF. So I'm talking about, what do you do once the nurse practitioner is, say she's assigned this lab. So do you, A, make your recommendations for follow-up in the lab log comments, so you type in your remarks or your comments what to do for follow-up? Do you just simply review the lab and make no comment, so you just, once you're assigned the lab, just review it? Do you go ahead and initiate a referral at this point in time? Or do you do both B and C? So for the answer for this question, it is D. You would review the lab with no comments and then initiate the referral. I'm not really going to get into assigning and acknowledging the labs or who's going to initiate the referral, the nurse or the nurse practitioner. But at this point in time, when we're doing follow-up, we know this patient's going into follow-up. The patient's going to need to be contacted. We're going to get into where to document that contact, but we're just talking about the lab results section right now. Okay, for lab documentation, review the lab, which will acknowledge or which will signify that you have looked at this lab. So that will have your name, the date, and the time. I didn't mean to say acknowledge. I didn't mean to say you would acknowledge the lab at this point in time. I just mean this is just confirming that you have viewed the lab. We do not want to document remarks in the lab results section. I know this is different than what we have been doing. A lot of people have been documenting a lot of their follow-up in this section, and I'm going to go over why we're changing how we're doing things. So we don't want to write examples like refer for colposcopy, co-test in a year, repeat cytology in 3 years, or any of the history in there. We don't want to write patient was contacted by phone and left a voicemail, or we sent her a letter, or we don't want to write anything. So that seems pretty simple, but I know we're going to have a lot of questions on, well, what do we do now? So the reason why, or one of the reasons why, is this is an example of what the patient portal will look like when it goes live. And as you can see, all the comments that have been said about this lab, the reviewed statements, the acknowledged statements, everything that has been said will actually transport to the patient portal once this is active. And then this is just a photo of this was just a test where we added a lab and I reviewed it, and that's all that should be there. So it would just have the nurses would also have the same, their nurse's name, the date and the time, and the nurse practitioners would have just the nurse practitioner's name, date and time. There won't be any comments made in this little lab section. Okay, so the question is, why should there be no remarks made in the lab results section? Is it because this is a medical legal document? Is it because of the patient portal? Is it because we're trying to standardize documentation, or is the answer all the above? Well, the answer is D, all the above. The most important, or one of the biggest concerns we have with documenting the lab results section is this is a medical legal document. This document is going to be available for the patient to view. We want our remarks to be very professional. We want our remarks to be very correct. And sometimes you might have a case where the nurse thought that we should co-test in a year, but then the nurse practitioner reviewed it and said, no, I think we should do a referral for a colposcopy. Well, that can be very confusing. Sometimes the terminology we use is foreign to patients. It's just not the appropriate, the patient should not see this documentation. And we don't want to say or document anything that could come, that if we ever had any kind of issues, that there were any kind of reasons why we should not document that. We don't want to look like we are correct in what we're doing and recommending, so we just want to be very careful how we document, and we want to be very correct in how we present ourselves. Okay, so I just thought this was a cute little picture because I know that through the past year we have learned a lot of things. We have had to unlearn a lot of things, and we've had to relearn a lot of things. I do think there is something positive that can be said for having to do that. Just think about all the improvement that you'll have as far as fighting dementia and coping with stress by learning new skills, and it improves your memory and your self-esteem. So I think it's very positive, or I'm trying to make it very positive that we are learning new things and we're trying to improve our cognitive function as we progress through the EHR. So after you have reviewed the lab, where do you document your follow-up steps? Do you document them on the lab? Do you document them through a referral? Do you document them through the notes section, or do you document your follow-up steps in the task section? The answer is B. You will go to the referral portion of the EHR to document your follow-up steps. So I think what has been really the most confusing about our follow-up, and I'm really going to get into referrals and the progress note, but the word referral has been somewhat confusing. But when you generate a referral, this could be done for any abnormal finding. We just need a place to document what we're doing for follow-up. So if you have an abnormal finding, a diagnostic mammogram that needs follow-up, PAP smear follow-up, these are all cases where you would need a referral generated. The referral section and the comment section within this referral acts as our progress note. So I think for the purpose of the rest of this presentation, I'm going to start calling the referral the progress note, because this is not technically our patient referral. This is our progress note. Until, if we do have a progress note developed, that things might change, but for the intents and purposes of this program and what we're doing right now, the comment section is our progress note. So this progress note will track our entries for follow-up. So our phone calls, our letters, our certified letters, what's going on with the patient's follow-up care. Like we did on our abnormal PAP and abnormal breast follow-up note in the CHR, these are our progress notes. And this is not a list, all-inclusive list of why you should generate a referral. These are just some examples. So to start a referral, some of these things some people may already know, and this is just additional information, but for some people that are newer to CureMD or are going to be doing follow-up and haven't really looked into this, the referral is kind of hidden under the registration tab in the tree menu. I think it's a good idea to go and change your preferences to expand that tree menu. That just means it's not collapsed, and so you can see the word referral, which is our progress note, so that it's visible so you can find it. It's just easier when it's not tucked away into some hidden corner of the EHR. Okay, so the first question that always comes up is it an incoming referral or is it an outgoing referral? For most cases, we're going to be doing outgoing referrals, and it really, as I said, it's more of our progress note, but you do have to choose incoming or outgoing. But an incoming referral to me is someone that is coming to us for a service, such as an implant insertion. And outgoing is something as we're sending this patient out for further follow-up with another provider, or we need to document follow-up within the health department, but we need to do that in-house. So this, on the left side of the picture, you see registration. It's a little blurry, but it's expanded, so the word it's under registration. It says profile, then referrals, family, patient name, letters. So that's where you generate your referrals, and there's incoming and outgoing. Okay, and this is what the referral looks like. So this is our progress note. So we want to start by entering the effective dates. For our purpose, we don't expire referrals typically. We leave the dates as if it was October 1st when we're starting this referral, you could leave it at October 1. You don't have to do it. Say you just need them to complete whatever you need in 3 months. You don't have to do February 1. We usually just use the same date for their effective dates. The plan is their insurance or the type of coverage. The referred by is typically the nurse practitioner name, which either she may or he may have been the one that did the exam, that collected the PAP smear, that did the breast exam where you had an abnormal finding, the nurse practitioner involved in the case. There are some cases where the collaborating physicians' names are appropriate to put here. It does get hard to track our referrals when we do it by Dr. Thomas or Dr. Maxwell's name, because they have so many more than a nurse practitioner would have. So it's just easier to track referrals when you do the referred by as the nurse practitioner name. Now, the referred to has been difficult sometimes to figure out what do we put in that section if we don't know which physician they're going to go to for their colposcopy, if we don't know where they're going to go. This can be changed at any point in time. So you can put the physician's name or the clinic that you think they're going to, the healthcare facility, or the health department. You can create providers. You just have to be careful to remember which provider, what name you called them. I've created some which was just the health department's name as first name and health department as last name. So like I said, this can be changed, and you can add a provider without an MPI. But we probably by now have already developed a list or have a list of we know where we're going to refer to, and it makes it easier. But it can be difficult if you don't remember what it's called to search it to find the referred to portion. And this isn't a referral that's actually going to go to this provider. So it's just one of those requirements that you just have to fill in this box to satisfy the system, but it can be changed. Then the next portion, it says visits. That typically stays at 0. Status can be changed from in progress to complete once you do complete your referrals. The assigned to function can be the follow-up nurse that's going to continue to follow up on the referral, or the nurse practitioner's name can go there. It depends on what you're doing, what you're going to put there. And in-house is just when the referral's inside the health department, but it doesn't change how the referral actually operates because, like I said, this is our progress note. But you do have to enter certain things so the referral will save and it'll let you continue on with your follow-up. So the reason, this is what shows up as what's on your dashboard. So you want to try to be specific. There's not a lot of room or abilities to use certain characters in the reason, but you want to say something about abnormal PAP follow-up, needing colposcopy, and we're going to go into a little bit more about changing the titles of things that could help on your dashboard when we get into your task. The referral number and the prior authorization number or the pre-authorization number are all just today's date. And then the important part is the comment section, because that's where you're going to document your follow-up steps and just make sure you save it. And this will have your name and your date and time all attached to this. And you can continuously add comments to the section. So it's just a chronicle or a log of everything that's happened for this patient as far as follow-up goes. And then there are on the next line talks about resources, urgency, service type. You can, choose as you see fit depending on the situation. But most of these are not, you don't really have to complete every portion of the referral to save the referral. So this is just a test referral that I did, and I filled in some information, typed some comments, and I just edited the referral. So I want to talk next about what is called the referral details report, and then what is called the patient referral and data exchange. Okay, so when you print the referral/progress note, that is actually called the referral details report. So that is this picture. So it's called referral details. So this is everything you entered on your progress note. So under notes, all the details about your follow-up are listed there. So I think for a lot of people, we have been using this as what we give our patients. So I want to change that. And we want to start using the actual referral that's under letters where the patient can sign, and we're going to go into that. So this is our progress note. This is not was not really intended for a patient copy of the referral. We have just learned more about how to better use the system and what we could use. So we're going to use the referral progress note as a way to document. That's our progress note. And then when the patient needs a referral or you need to give a referral, that's when you give the patient referral and data exchange, and that's like our CHR5. And it has a signature line for the patients to sign for it. So this is your patient referral and data exchange. It is located under registration, just like referrals was. It's under letters, and it's called ADPH patient referral, and then it's got the patient signature on it. So there's 3 pages, or 3 slides about this. So you can fill in where the patient is going to be referred to if you know that information that day. Just make sure your health department information is correct, your phone numbers, fax numbers. If you make the appointment, you can enter that for the patient on there. There's reason in yellow. You can you type the reason for the referral, and you want to be very specific about what you need follow-up on. That you have a 34-year-old gravida 2 para 2 that has a low-grade PAP smear, HPV positive. If she had any PAP history, you would include that abnormality on your exam, and that she needs follow-up in a colposcopy. So you don't want to send the patient out with the referral and just say PMD of choice or be very vague about what's needed. We need to be more specific about what we're actually referring for. And any additional health problems and referrals, you can document that, and then the patient can sign. And it authorizes the release of medical information on that patient back to us. So we also had a lot of questions about the patient's signature and getting records back. Okay. And that's just the bottom part, which was our bottom part where the patient, where the provider, the consulting provider signed. So on our progress note at the bottom, there is a place for diagnosis and procedures, which some people were entering. Say there was a low-grade PAP, you could put the diagnosis code for that, the colposcopy procedure. What I think is really nice and what's very helpful is attaching the documents there. I think that's very helpful for anybody that needs to review that chart so they don't have to go searching around the EHR to find the follow-up records. So you can scan or upload your documents right into the referral portion, and then your colposcopy records or your surgeon's reports, mammograms, everything can be right there. Name those appropriately so you can find them, but I think it's really helpful to upload them into the referral versus just going to the document manager and doing that. They will be in the document manager, but it'll be under the referrals tab, so it won't be under, it wouldn't be like you're uploading to the document manager, so it'll be under breast and cervical, it would be under referrals, and then I always go to all documents just so I can see every document, but it would be there. So you just need to be careful what you name them, because if you just name them lab or PAP, and there's several PAPs over the years, you want to be specific so you can find your documents without having to open several. And there's just a little information about breast follow-up. We want to continue to utilize breast follow-up to the central office, so the abnormal breast consult template, which is in Lotus. So we've kind of gotten out of the habit, or sometimes we forget, that our CHR 12 is now our EHR note. So the physicians really need to be able to read and see that breast exam and review your notes. So you want to make sure you attach the EHR note into the consult. And the same goes for once that consult is completed, and by complete I just mean that you've gotten a response back from the physician, that is either scanned or uploaded into the EHR. So just as we used to print the consults, punch holes in them, and file them, now we can upload them into the EHR. So it doesn't matter if you print or scan or if you upload them as a PDF, as long as they're there, just so that everything is in that patient's chart. So now we're going to talk about task. A task is generated when you start a referral. And this has been helpful for some people. They go in and change the title of the task. They don't change the title of the referral, but the task itself, you can go in and change it. And because over time, you get so many tasks on your dashboard, and you get bogged down and you're not sure which one you're supposed to work or which date. Sometimes just changing the title, that this patient is an abnormal PAP follow-up, certified letter needed. Some nurses have worked out systems where they just change the title to help them. So, but it really depends on your practice and how it works for your clinic, but that has been helpful for some people that are doing follow-up to keep track of it. And then you can change the status to in progress, complete, and you can complete and hide. We don't want to, and I'm going to get into deleting things, but you can also assign multiple providers in a task. There have been times where I've seen a patient and I needed to assign it to the nurse, and I did that on the progress note or in the referral. But then the nurse practitioner that would be at that clinic when I wasn't there, she needed to know about this follow-up too, so I went in the task and assigned it to her also. The task does have a note or a mark section. You don't need to document there. Everything you document on your progress note or in the referral is going to go automatically into the task. So it's not going to work the other way around. So when you document in the referral, it automatically shows up in your task. So you don't want to document in the task because it won't go back to the referral. So it's just because there's so many different ways you can document, we're trying to standardize that. So when you do document in the remarks section, that's the only place it's going to be visible. So we want to try to document everything on that progress note. And this is just an example of a task. There's a note section, which is exactly what I wrote in that referral that just came right over to the task, where you can assign more than one nurse practitioner or nurse. And this is where you can change the status to complete once you're finished with your documentation. So let's talk about when we don't have to actually do any additional follow-up. So some examples I thought about were when we have a urine culture that's sent off, or when we do a screening mammogram. How do we document some things that are not requiring additional follow-up? So let's talk about the urine culture, or any lab that you need for a patient. So the patient has a urine culture sent off, it comes back, and it's sensitive to the antibiotic that was given. Well, you need to be able to document that you reviewed that lab, and you need to have somewhere to document if any other follow-up is needed or if everything's done. So in this case, she's sensitive to the antibiotic you gave her. I would append the note and make that documentation, because we don't want to document on the lab. So document that she was treated appropriately, no further follow-up was needed, and that kind of closes that loop, so you don't have a urine culture on that note just pending and we don't know what kind of happened with it. Screening mammograms. When we first started, we were trying to find a way to document when a mammogram came back to us. And what we kind of, some concerns we got with that was we're documenting, or we're developing a lot of referrals for a screening mammogram, which is also bogging down your dashboard, and it's difficult to navigate. So an idea came up about with screening mammograms, the breast exam is normal, there's no family history that we're worried about, there's no abnormality. So you've ordered a screening mammogram and it comes back a BI-RADS 1 or 2, so it doesn't indicate any further follow-up. So where can you document that? That mammogram would be scanned into the document manager. You can review that, but I wouldn't document there. I would append the note and document that there's no further follow-up needed. Screening mammogram was the result, and continue annual screenings. Instead of generating a referral that generates a task that causes you to have to complete it. Some people were concerned with, well, how is the nurse going to know? Because some did like the assigning function of that. They could either get a copy or assign the note to the nurse about that. There's different ways to do it. We were just trying to come up with possible other options instead of generating a referral or progress note. Now, if the patient came back and she had a BI-RADS 3, then that's follow-up, and you would start the progress note. And this was just the append the note portion, where you can actually, you have 1,000 characters to say what you need to say about follow-up, or say what you need to say about this lab result that doesn't require follow-up. Phone encounters. Phone encounters are not to be used to document follow-up attempts. One of the reasons is we want all the follow-up to be documented on that continuous log and that progress note. It does get hard to find things once you start, the patient comes in for multiple visits. If she comes in for an initial and a supply visit, and then you have a phone encounter, and in each note you might document a little bit about follow-up, there's a chance that things can be lost. So a phone encounter is not an appropriate place to put follow-up documentation. A phone encounter could be used if a patient calls and she's having some breakthrough bleeding and she has some birth control issues that's not pertaining to her follow-up, or she's in PAP or breast follow-up. That all would go on the referral. So if you do speak with the patient by phone, you would document that on your progress note. The banner is to me like our CHR1. So when you would open that chart, we would write things on that left side in red that we needed to flag. So the next person that's seeing the patient, if it wasn't us or it wasn't a nurse that's doing the follow-up, would be able to know where to go and know that there is something that's going on with this patient. So you can use the notes on that right-hand section to document breast follow-up, abnormal PAP follow-up, consult, referral, and you can complete those notes. Say something does resolve, you don't want to delete it, but when you complete the note itself, it will actually just go under patient note. It will go under the notes section of the chart. So we don't want to delete anything out of the document. Just some additional tips. A lot of clinics have one nurse practitioner. It's the same nurse practitioner every time, so there's no confusion about this. But if you are seeing a patient and there's multiple nurse practitioners or providers available, you want to make sure that the correct provider is listed for the note. So say Dr. Thomas is listed for the note, the nurse starts out the note, but then I'm going to see that patient. I want to go in and change it where I'm the provider for that patient. So there is a little orange box that shows up, this little tiny arrow, and it's orange. It's under letters or create super bill, and it opens, and that's where I can change the provider to my name. Because say you did leave that as Dr. Thomas and you needed to submit a consult, it's strange when Dr. Thomas is the provider and she's consulted on a note that she was the provider for, and she has to consult and sign off on that note. So we just want to be aware of who the provider is listed, and we can change that. We can't change the note template, but I can change the provider. Another little thing that's helpful once there are several notes is it's very small, but up next to visit and the date, the blue date, there's a little piece of paper with an hourglass or magnifying glass. Those are visible in the provider notes. So if you have 8 provider notes in the past year, so you don't have to go in and out of each note. If you click those, it will open all the notes kind of on top of themselves, and it's so much easier to review the record at one time because it's very difficult when you're busy in the clinic to open every one of the notes. But to make sure that you're seeing the patient appropriately and you know what's going on with the patient, you need to review the previous notes, and that seems to be an easy way of doing that. And I think that is all for my presentation. If you have any questions, please email or call us, and I'm going to turn things over to Ms. Deborah Davis.
Thank you, Krista. I appreciate everything, all the remarks that you made on the referral notes and everything, and made those definitions very clear. I'm going to speak a little bit about referral myself, so we're going to proceed on into this presentation. First of all, I'm going to show you a picture from my neck of the woods. This is Nakalula Falls in Gadsden. The objectives that we have is that we're going to cover the 6 steps used in follow-up. We're going to demonstrate how to properly document any information that's received about PAP smears, colposcopies, the mammogram, ultrasound reports, pathology reports, and any other abnormals that we may get in. I want to make a mention to you too that these steps are slightly different from the ones that are in your clinic protocol manual right now. We are going to be changing those to reflect what we've said in this presentation today, and that'll be coming out to you soon. So, what is the purpose of follow-up? It's actually to outline the steps ensuring that patients receive timely, evidence-based, researched education and care. It's also that they receive the recommended therapeutic plan of care, and that we confirm completion of the entire process. We want to make sure that our patients receive the highest quality of care. We would want the same ourselves. So again, what is the purpose of tracking? We want to make sure that all the results are received, the results are followed up, and that all abnormal findings are followed through to completion. This would include everything that we've done for the patient. It would also include the referrals that we give patients. I know sometimes we give those referrals and send patients out, and we really don't track those down to find out exactly what happened with that patient. But if a referral is given, then we need to track it. So what is the standard of care? The standard of care is the level and type of care that any competent, skilled, and professional would give to a patient, and it's like any other medical professionals in the same circumstances would give. And we follow at ADPH a standard of care. We want to provide the very best research-based care that we can for our patients. So after a referral is given, the records need to be obtained. We don't really want to have any kind of gaps in our patients' care. And the reason that we send patients out is that we may need to have some kind of technical expertise outside the scope of practice for the health department. We may want somebody to really look at this patient carefully and give a correct diagnosis, and we want them to give an appropriate course of action to follow up with this patient. These are really our patients. When we send them out, when we have an abnormal or find an abnormal with their examination and we send them out, we're really seeking guidance from the person that we refer them to. And so because they are our patients, we want to find out what their recommendation is for their follow-up. We also want to have provide safe care for our patients. We want to have efficacy in our patient care and our clinical practice so that we don't end up with bad outcomes. And you might think, well, what kind of bad outcomes can we have? We don't want any harm to come to our patients, and so we also don't want any kind of legal action ourselves. So the first step in the follow-up tracking process is that we're going to provide, if an abnormal comes in, we're going to initiate a tickler tracking system. And this is going to follow all the abnormal results, and it's going to follow any referrals that are given the day of the exam. So this is also going to require a review and a signature. And so what's going to happen with the second step is after the nurse or the nurse practitioner reviews the abnormal lab results, we're going to do that electronic signature, and there'll be a date on it as well. I wanted to kind of back up and say, or I may do that forward in just a second, talk a little bit about what additional things that we'll put there. First of all, the nurse and the nurse practitioner should read all the information that comes back in its entirety. We don't want to skip anything, and that always brings to mind a situation that happened several years ago about a nurse practitioner who got a BI-RADS-2 mammogram back. And you'd think BI-RADS-2, everything's okay. But she didn't particularly like the wording that was going on in that mammogram, and she ended up consulting with the collaborating physician and referring that patient out. And that BI-RADS-2 mammogram really ended up with that patient having breast cancer. So it's very important to read that report in its entirety. If something just doesn't click, pick up the phone and call your collaborating physician, and y'all try to work through that and figure out what's going on with that patient. When you get an abnormal finding, you don't want to delay any kind of appropriate referrals. You know, if the nurse practitioner is not there in the clinic that week, you want to, or she's not there that particular day, and the nurse recognizes that it is an abnormal, go ahead and make that referral, and then the nurse practitioner can sign it later. Remember that all abnormals are followed up until they're completely resolved, and if there's any questions about the results, or if there's any kind of discrepancy or anything contrary to our guidelines, then a consult is needed, and that can be either done by the nurse or the nurse practitioner. So if the nurse practitioner receives the abnormal test, the nurse practitioner can initiate that referral note, that progress note that Krista was talking about, and she can write on there, on that referral note, progress note, what further care is needed for that patient, and then assign it to the nurse. If the nurse receives the abnormal test, then the nurse can initiate the referral note and assign it to the nurse practitioner so that that dispensation note can be made. Another reason, Krista went over the reasons why we don't want to write things on that lab note page, is we don't really want the patient to see all of the things that we write there. First of all, we may not have had an opportunity to contact that patient by the time they look at that patient portal, and they see all these notes on there, and they may have some confusion about the terminology. Also, they may share that information with somebody with them, and you know, we have to be very careful as far as confidentiality, what we write there and how it's written. So really all we want there is the name and the date, whoever has reviewed it. We don't really want them to see that plan of care until it's established and they've been appropriately counseled. So this next slide, I kind of blacked out some names and everything because this was an actual patient. The patient can see everything that we write there. So we definitely do not want to do this. We want to initiate a referral progress note, as Krista calls it, as we document any information. The third step in the follow-up tracking process is that we're going to initiate that follow-up within 5 to 7 business days of receipt of this abnormal result. We're going to initiate it by doing a phone call. If we can't reach the patient with that phone call, then we're going to send that first-class letter. If there's no response to that first-class letter within 2 weeks, we're going to send a certified letter. If there's no response to that second certified letter within 2 weeks, then we will have no further follow-up for that condition at this moment in time. We need to document clearly any and all attempts to contact the patient. We also need to put a notation in the right side of the banner and list it as high priority, and any follow-up abnormal results should be addressed and documented at every clinic visit. Remember, if the patient refuses any kind of further follow-up, they can sign a declination services form that we have in the clinic. But I do want to make mention that from the very get-go, when a patient has an abnormal and you have concerns about whether or not they're going to follow up, enlist the help of your care coordinator. Our social workers are they have lists of kind of resources that we as nurses and nurse practitioners don't have. So we need to enlist their help to try to assist this patient get the services that they need. And so this is the note, the type note that you'd put in the banner in the top right-hand side. And so when that patient comes back for a clinic visit, you want to make sure that you do a follow-up note in your progress note. And this is an example of what that note might say. The patient is in clinic for supply today. She has a history of an HCL with a positive HPV that requires a colposcopy. The patient was counseled on a particular date and could not go for colpo due to lack of insurance. The patient is counseled today regarding need for further evaluation of her abnormal PAP smear. She was counseled that the recommended plan of care is colposcopy and probable biopsy to determine the specific information about the abnormal cells on the cervix. A follow-up appointment has been scheduled at UAB Colpo Clinic on a particular date. She's been counseled about the consequences of not following up on this abnormal test and that it could lead to a progression in her disease and possibly cervical cancer and result in death if not treated appropriately, and that the patient verbalizes understanding of her counseling. And you could additionally add referral to social worker for assistance with transportation or any other type of assistance that that patient might need. So let's recap. I'm going to back up as I recap these steps. So the first step is that we're going to make a tickler. That's very important. The second step is that we've reviewed the abnormal and we've signed it electronically, and a referral note has been created in the EHR, and disposition notes have been recommended by the nurse practitioner. The third step is that we've initiated a phone call or the first-class letter within 5 to 7 days, and the second letter, if no response, within 2 weeks. The fourth step is when the patient is reached, then they're going to be educated on that abnormal result, and an appropriate appointment is made and a referral is given. And I do want to caution, if you are giving a referral, make sure that it's not the MD of choice. We need to be specific for the needs of that patient and the situation. The fifth step is that we're going to assure that the follow-up appointments are kept and the records received. For instance, I put 30 days after the appointment, but that really pertains to the PAP. We want to make sure that we've received everything for an abnormal PAP within 30 days afterwards. All records, for example, again, I used an abnormal PAP. If they've gone for a colpo, we need to make sure we get those notes. If they've had anything that could indicate a biopsy or a piece of tissue was taken, such as with a cold knife comb, we need to make sure that we have all that information back, and that we'd really like to have that plan of care too. Does Colpo Clinic recommend that they have a follow-up PAP in a year, or what is their recommendation? I also want to make mention right now that if a patient does go to the UAB Colpo Clinic and you haven't received any follow-up results within 2 weeks after their appointment, you need to contact Dr. Thomas with an email and CC it to Lizenia Lawson. Through their ambassador program, sometimes she's able to get those reports more timely than we might be able to. So that would be your contact if you can't seem to get your results in a good time. The sixth step is that the follow-up is not really complete until all your information has been received. So, for instance, if they went for a colpo, you've got that post-procedure notes, and some kind of recommendation is made. If for some reason you look at it and something just doesn't seem quite right, you're going to consult your collaborating physician, and especially if it's outside ADPH or the ASCCP guidelines. We're going to follow that patient until they return to their routine screening. So we're going to make sure that we document all pertinent information about that patient, and where we're going to put it on that referral progress note. It's not going to go on the lab form itself. Tickler cards should be made for all abnormal results. I can't emphasize that enough. So when when everything is complete, all information is on that tickler card as well, and it can be scanned in and uploaded to the document section. This is a medico-legal thing. We can't just throw those cards away. They do need to be uploaded to the document. This is an example of your tickler card. Most of you have seen those. And I'm kind of being very basic about all of the things that I'm saying today, but we do have new people that come in all the time, new nurses, new nurse practitioners, and some of you, the nurse practitioners are doing follow-up, and some nurses do different kinds of follow-up. We want to make sure that you develop good habits right from the get-go. So tickler cards are very important to be used. Put basic information on there about what your next step is going to be for that patient, and then keep that in your locked tickler box, and then you can follow up with your patient very carefully. If for some reason you don't have this tickler card, you know, we can't always remember all the patients we have. And so you don't want this patient to be forgotten. You don't want there to be any gaps in their care. So if the system were down or you couldn't remember the patient, you've got that tickler card system to fall back to. When that tickler card, this is the example, when they go back to routine screening, that's when you want to scan it in and upload it to your EHR documents. So again, I know this is very basic information, but it's important that we state this. We can't emphasize some of these points enough. A phone contact is when that patient or guardian is successfully contacted, and the importance of the recommendation for that abnormal is discussed with them. They've been educated appropriately and counseled about that abnormal, and a referral is given. If you make a phone contact, you don't want to give anything other than your name. You could call and say, my name is Deborah Davis, or my name is Deborah. My phone number is 5698118. Or, you know, please have patient XYZ contact me. You don't want to leave a message that says, this is Deborah from the health department, please have this patient call me. So we have to remember those guidelines as well. You also can't count that phone call as a phone call just because you've left a message to have them call. You have the counseling and the documentation about what you plan to do with that patient all needs to be done if you count that as a phone contact. Your first-class letter to the patient is only to notify or to contact the health department. Do not educate or counsel in this first-class letter. And then within 2 weeks, if the patient hasn't returned any contact with you, then you're going to send the second-class letter. If for some reason the first-class letter is sent back, and unless there's some kind of technical reason, such as insufficient postage, you will not send that second letter. Remember, too, that the certified letter is one that the post office requires a signed receipt, but anyone can sign for that certified letter, so it might not be the patient. We like for it to be the patient, but it doesn't always happen that way. Escalating attempts is what this is all about. We have a better chance of success in contacting this patient if we initiate our phone calls and our letters as early as we can, preferably getting them started within that 5 to 7 days of receiving the abnormal finding, and if they have no response within 2 weeks, we initiate that second certified letter. We have to keep in mind that our patients are transient, they move frequently, they change their phones a lot, and the sooner they're contacted, the better. We can't wait 30 days down the way to start initiation of contact with this abnormal finding. When we do our documentation, we want to put who was counseled, whether or not it was the patient or their guardian, where and how they were counseled, was it over the phone or in the clinic, the description of the abnormal findings, such as an ASCUS HPV positive PAP, what our treatment recommendations are for the patients, what that follow-up appointment is, and the consequences of not following up with those recommendations. It's very important to initiate that, as I said, between 5 and 7 days of receiving the abnormal finding. For breast follow-up, we're going to try to finish that follow-up within 30 to 45 days. For PAP follow-up, it should be within 30 days. Remember that all suspicious breast masses, those with especially a BI-RAD 0, 4, and 5 mammograms, need to be initiated immediately. Also keep in mind, and we've said this before, and I think one of my other colleagues said this too, if it's not documented, it didn't happen. So it's very important for us to document every attempt that we make to try to reach the patient. We also want to document the risk in counseling every clinic visit. So if a patient comes in and they're for supply, don't forget to look at that banner. It should be in red, in high priority in the upper right-hand portion. If they've got an abnormal breast follow-up or abnormal thyroid or abnormal PAP, we want to make sure we look back through those documents, see what's been done, and counsel the patient appropriately. We also want to remember that any person who does not follow up, or for some reason we haven't been able to contact them and we're able to talk with them about it today, we should never deny them any kind of ADPH services. And especially, we don't want to deny them their birth control method. That's totally independent of their follow-up compliance. I want to mention one more time about involving your social worker. sometimes we may not realize exactly why the patient is not going for follow-up. And so we need to explore that with the patient. You know, they may say, well, I just don't want to go. Well, we need to ask some additional questions. Do you have transportation? Do you have somebody to keep your children? We need to try to figure out why that patient is not complying so that we can do all we can do to get them in for their follow-up. That's very, very important. I want to mention too, if this patient has gone out, especially for a PAP, and they're referred back to the health department, we are going to follow we're going to follow our guidelines, and we in the health department follow UAB and ASCCP guidelines. Remember, I mentioned earlier on that those were the standards of care. Some of these folks may choose to go to a community physician and then come back to us for follow-up. Well, that community physician may not follow the guidelines exactly the way we want it done. And so if there's any kind of discrepancy in what the physician is sending back to us, then you need to contact your collaborating physician. I also want to make mention, if you talk with one collaborating physician 1 week, you get something, you know, some additional information, don't call another collaborating physician. We need to make this smooth information. If you're talking to one physician, you need to keep talking to that one physician about this one patient. Krista mentioned this, that your abnormal breast fall will continue to be in the abnormal breast consult template. If there's an abnormal clinical breast exam and your mammogram results as a BI-RADS 0 initially, and then with a follow-up study being a 3, 4, or 5, it must go in this abnormal breast consult template. And I also want to make mention, if there is a positive clinical breast exam, if there is a lump or a mass found, that patient does require a surgical consult regardless of what your mammogram or ultrasound show. If there's a mass there, they need to be evaluated by a surgeon. Also, if that patient has had a previous, maybe a needle biopsy for a lump that was found 2 years ago, and they show back up for their annual and you're still feeling that lump, unless there's been an excisional biopsy, they're going to require a biannual ultrasound, and they need to be followed up annually to assess the stability of that mass. We don't want to just say, well, they said 2 years ago it was fibrocystic breast. You know, they need to be reassessed, so we're going to send them back out for their workup. I wanted to make mention of a family history with breast cancer. If there's a strong family history of either mom or sister or daughter with premenopausal breast cancer especially, our antennas should go up. We need to fully assess, you know, all the members of the family that have had these issues going on and exactly how old they were. Get a more thorough assessment and follow-up. This patient may require to be followed up for some kind of genetic testing. I'm going to have a case study here. This is actually a case that happened in the health department. This is a 45-year-old who came in with a positive palpable breast mass. The nurse practitioner sent her for a diagnostic mammogram. It was ordered, but the patient missed her appointment. So what would you expect would be the next recommended step for this patient? We don't have our timer and our music today like they do on Jeopardy, so I'm going to say the nurse should try to, or the nurse practitioner should try to phone the patient. Remember the follow-up steps. Where she had an abnormal, so we need to at least try to call the patient, send that first-class letter, and if no response, send a certified letter. Remember, every month we get a message from ABCCP too about the recommendations for that month. We need to review those in case there's any kind of differences. You know, it may be that this patient could be followed under ABCCP. Nonetheless, this case happened, and what really happened is that she had this palpable breast lump. She missed that appointment. the collaborating physician all of a sudden received information in the abnormal breast consult template, and this is what the records show, that there was an abnormal clinical breast exam, that a diagnostic mammogram was scheduled, the patient missed her appointment, and then 4 months later, a certified letter was sent. This is very important that this doesn't happen. There was no other documentation on here. That puts this patient at risk. So again, we need to document every attempt to contact this patient and follow the steps the way it needs to be done. The patient showed up at the imaging center 5 months after her appointment was originally set. She told them that her car broke down and they worked her in that day. And so a mammogram and ultrasound was done. The diagnostic mammogram and ultrasound showed BI-RADS4 and a biopsy was recommended. The radiologist sent that patient for referred her to a surgeon, and an excisional biopsy was done that showed adenocarcinoma, and the surgeon referred her to an oncologist for a plan of care. So my next question is her follow-up complete? I want to make a point here by saying, how would we feel if we were in the position of this patient and we missed our appointment, nobody called us, nobody tried to reschedule us? We really would not have wanted a 4-month delay in trying to receive help for our health problems. This patient had cancer of the breast. But, you know, what if somebody had called her and said, oh, I'm sorry, you had difficulty with transportation. Let me put you through to the social worker and see if we can't get this rescheduled for you. So it's very important. The main point is that we've got to follow these patients. We've got to follow them through to completion, and every step and every contact attempt needs to be documented. So how do we follow up on a routine screening mammogram? So a patient is scheduled for a routine screening mammogram. She has a negative clinical breast exam. We want to call and verify that the appointment was kept. We want to get those results in, and we want to document what those results are, and Krista has already discussed that. If for some reason that appointment is not kept, then we don't need to do any further follow-up on this routine screening mammogram. We saw the beginning of Nakalula Falls. When it goes off the falls, it goes down a stream, and I thought this was a really pretty picture to put in here at the end of our presentation. So this is what happens after it goes over the fall. I think I'm going to put our name and phone numbers up here. If you have any questions at any point in time, you can call your nurse practitioner seniors, or Beth Allen, our nurse practitioner director, or Dr. Grace Thomas. We will be happy to answer any kind of questions that you might have about follow-up, the EHR, and we do appreciate all the work that you do. We know that you work very hard at your follow-up, and you do an excellent job. And I'm really going to turn this back over to Beth Allen right now for any additional questions that might have come up through this presentation.
So, do we have any callers? I don't think we do. We do have some email questions, so I'll jump right into those and stop if need be for anybody that wants to call in and ask a question. We appreciate all your questions. We had a question from the field that says, when a nurse practitioner gives a fit test and it is returned and developed, where is that result documented? So specifically, that could be in the functionality where Krista was talking about, to append the note and actually put those results on your note. Then it's all within that same patient visit, if you think about it. It's just an additional documentation piece on that note. Next question is, where do you document your attempts to contact a patient if she does not go for her mammogram? Deborah covered some of that, I believe, but that could also be documented. You know, we said if it's a screening mammogram. Of course, if it's a referral, it goes to the referral progress system if it's abnormal. But if it's attempts to where you're trying to show that you've tried to contact the patient, that could also go to the appended note where that mammogram was originally ordered. So that's my, if we have any further clarifications to this, we'll send it out by email, but that's my first thoughts on that question. Another question, I was told each time we refer a patient out for a mammogram, we should create a referral in the referral tab. When the results come back, I scan them into the referral and write my comments in the comment box. Why do we need to go to the provider note and do that again? So the actual example that we were giving on the mammogram would be if the clinical breast exam was completely negative, there were no problems with the patient, it was a screening mammogram, and it came back as a normal result by RADS 1 or 2 that did not require any further follow-up, then you don't have to create a referral in that instance. I think that's the piece to clarify on this. That would just go as an additional note on the patient's visit, the day of that visit, and again, it would be all within that one patient visit and note. Okay, I'm going to go on to the next question. So to clarify, the nurses will be tasking us every time negative mammogram, and we are to append the note. So again, if the nurse, you can CC the nurse on that, or you can assign it to them. But if the mammogram is negative, it's a clinical breast exam that's negative, and it's a screening mammogram, we're trying to alleviate you creating the referral progress note because it's not needed. So all that can happen in the note itself and just append it. And that will take the place of the referral that we first recommended on that. If that doesn't make it clear, then just call us back. Okay, another question. Does a face-to-face discussion of abnormal PAP results fall under the first attempt along with a phone call and first-class letter? So obviously that's the best ideal situation. If you have a patient that's in the clinic and you're able to discuss their results with them face-to-face, then yes, that's what's needed, is that counseling session where the patient understands next steps. Okay. On a patient that went for a colposcopy and the MD recommendation was different than the ADPH guidelines, does the nurse practitioner have to consult the physician, or can the follow-up nurse consult? So I'll let Dr. Thomas expound on that, but the nurse can consult. I don't see any reason the nurse can't consult in that situation. Next steps is going to be referral, and if there's questions, you know, and needs that don't align with what we should do, then we have to contact our physicians for clarification. That's outside of our protocol. So that can be done by the nurse or the nurse practitioner. Okay, I'm going to stop just a second. We've got time, a little extra time that they've given us for this. We've still got some questions by email, but we do have a call from Tuscaloosa County. So caller, you are on. Go ahead.
Yes. Can we use the email address to contact the patient about abnormal PAP if we have permission?
If the patient has given you permission through the system to contact them through their email address?
Yes.
I don't know that we've established that in policy just yet through EHR development. So let us look into it, and we will get back to you on that by email, okay?
Okay.
It's a great question. Yeah. Thanks. Okay, we have another call from Morgan County. Caller, you're on.
Yes, ma'am. Thank you. I have a question regarding abnormal breast follow-up.
Okay.
This is a physical exam performed by the nurse practitioner in clinic, and a screening mammogram has been ordered. And those results are received, and they're negative of IRADS 2. And the follow-up nurse is now going to append the note with those results. Is that okay to append the note that has been signed by the practitioner, or is that something we need to refer to the practitioner to do?
No, you can do that.
Okay.
Yeah.
Thank you.
It's fine to do that, yes. Thank you.
Thank you. Bye-bye.
Okay. Let me get back to our screen. Okay, this question comes from Colbert County. Not making remarks under labs, is that for all labs including STD? DIS put comments about contacting patients, or we document whether they have been treated or not. So when we were discussing labs, I don't think we were discussing the STD process. That hasn't changed. I think that answers it in a nutshell. So the STD processes for follow-up remain the same. We're just making clarifications for our processes through the EHR documentation. Okay, and then we have been told by billing that only the one who signed the note should append it. Has that changed because it's the RN who reviews the labs and would be making the comments? Do you see any problem with that? Okay, yeah. I think that sort of ties into the caller's question. So as a whole, we've got the EHR staff here and Chief Nursing Officer here. So as a whole, we don't see a problem with that. If there is in any way, we'll let you know. But as it stands, you can actually append that note as the nurse, even if the nurse practitioner signed off on it. Patients have not been signing referrals for colposcopies for a few years. We have been taking care of it over the phone because it's a continuity of care and release is not needed. Do we have to bring patients back into the clinic to sign a referral now? That will really slow down the process. I don't know that we said anything that would change that. I mean, you can continue to do that. Was there anything that I missed on that? Yeah. So that's absolutely perfectly acceptable. We do want to expedite the care of the patient. Okay. Do we use a phone encounter to document we contacted the patient concerning unsatisfactory labs? For purposes of the phone encounter, the way we have outlined it would be when the patient calls us for needs and not when we are needing to do follow-up. If we're needing to do follow-up, then we would actually need to generate that through the referral. I hope that answers that question, because that is, unsatisfactory is abnormal until proven otherwise. So it would need to be generated that way. We can look at that further. If that doesn't satisfy that question, just let me know. Okay. Regarding the PAP follow-up referral, if the patient had LEAP last year and records and needs 2 negative co-tests, she's got a negative co-test today, but still needs another one. Used to, I would make a note to repeat in 12 months. Do I do a referral stating this now? So she's in a follow-up process. Yeah, she's in a follow-up process. So that's a great question, and she would need to be generated through the follow-up referral progress note process that we've outlined today. So I hope that answers that. Thank you. Under the task section on our home page, we are giving a link to click on stating that the referral is about. Once you click on that, there is no association with the name or the account number unless someone has included that information in the notes section. even when you click on the View Associated Referral, it does not give you patient name and or account number. This is very time-consuming trying to research who this referral is on. Is there any easier way that we can do this through CureMD would automatically pull the patient into the referral? Yeah, I'm going to let Krista go there.
Okay, so when you're looking at the task, you see the names of the people that are assigned and the patient's name. So when you click on the patient's name, I think my example said Teresa Test, it will automatically take you into Teresa Test account. So try that, but if you double click or you click onto the patient's name that's listed kind of in the center of the task itself, you jump right into the chart. And that'll give you the patient's note, and it'll take you to the clinical overview of the patient.
And usually that name is in blue, and when you click on that blue name, it will take you into that note, just to add to that. Thank you for the question. And we just had a comment of Happy Nurse Practitioner Day, and so thank you very much. That came from Yolanda Williams. Thank you. And do we have any other questions? I think that we have answered, hold on. Yeah, that's the very first question. So we've answered all the questions that I have thus far. I don't see any new questions that we haven't answered, but we do have a little extra time. I'm just going to give you just another minute or so to make sure you don't have any other questions, because we do know we've outlined changes and we want to make sure we're all on the same page. That's the purpose of us all being able to view this. Remember, this is a required viewing for both nurse practitioners and nurses for those purposes, so that we can all be on the same page. We certainly appreciate your attention and thank you for all that you do each and every day for our patients. I think that concludes our program. We have no other callers and we have no other emails. Thank you again. Have a great day.